Good morning, everyone. This is the continuation of our corneal lecture series, and I want to thank Parveen Nagra for arranging it this year. Our topic today are the corneal ectasias, and we're going to talk about keratoconus, keratoglobus, and pellucid. Obviously, today we are celebrating Cinco de Mayo. I hope you have not started to party too early. I have no financial interest in the subject matter of this presentation or any other. And we're going to make it a little bit interactive until you get upset with me, and then I can stop asking you questions. Obviously, the ectasias usually include those three entities: keratoconus, which you will see a lot of during your residency, 36 months, keratoglobus, which you will be lucky if you see one or two, and pellucid, which you'll probably see a couple a year. And we'll talk a little bit about that. But these are the classical pictures of the cone, the globe, and the inferior thinning that you see in pellucid marginal degeneration. So let's start with keratoglobus. Obviously, very rare. This is an ectatic condition, so it's non-inflammatory. It is present very early in life. The globe looks roundish, so the cornea is steep, but not extremely steep like you would have with keratoconus, and it's uniformly steep all the way to the limbus, and it's uniformly very thin all the way to the limbus. There are some systemic associations. You can read about them. I'm not going to bore you with that this morning. Is it an OCAP question? It can be an OCAP question. What you need to know is that the cornea is thin all the way to the limbus. It's steep, but not as steep as keratoconus. And the Descemet's membrane is also uniquely thin. Unlike keratoconus, it is not associated with atopy. Okay? How do you manage this? You know, just like you've heard the idiomatic expression, discovering sliced bread and hot water, we have rediscovered scleral lenses. And been around for 50 years, we've rediscovered them, basically because of all the work that was done in Boston with the PROS lens. But there are other types of scleral lenses. If you can fit a scleral lens over this bulging cornea, these people can see very well. You cannot graft them easily. If they come to a graft, you need to do basically a limbus to limbus or corneal scleral graft as a staging procedure, and that will be a tectonic graft, and then come back and do an optical graft centrally. The problem with these is the cornea is very thin. So, as you know, just like you would in a post-rupture globe, or post-PK, the biggest recommendation that you're going to make to the patient is, Nate? Somebody comes to you, their vision is 20/70, you're not going to recommend a transplant, they're 15 years old, mother says, can we do anything?
Protection.
Yeah, they need to wear protection, and they're not the best candidates to play football. All right, let's talk about pellucid. For those of you who came to our Saturday morning dystrophy symposium, this is obviously not a dystrophy, but for those of you who came, you may have seen the one pellucid we had up on the 12th floor. It's more common than keratoglobus, not as common as keratoconus. Nobody really knows the etiology, but the protrusion, as opposed to being central or inferior central, is just above the area of maximal thinning, usually above the 2 millimeter point superior to the 6 o'clock limbus. You don't see any vascularization or lipid deposition. The vision is usually poor, and the vision is poor because the astigmatism is dramatic. Okay? It's not extremely irregular. You know, we call it high regular to irregular astigmatism, And I'll show you some topography. Equal between men and women, usually diagnosed early, 20s or 30s. So this is the sagging bow tie pattern that you see in pellucid marginal degeneration, or the crab claw pattern. But also note the marked flattening in the vertical hemimeridians. Marked flattening. So much so that if you took a slit lamp and looked at these patients, you can, just looking at the beam on the slit lamp, it's very flat. This is unique to pellucid. Now the question is, how do you manage those? Almost all of those can be managed without a graft, with the appropriate contact lens, usually a larger PMMA lens. Rarely do you have to go to a scleral lens, but obviously that's an option. If they can tolerate the scleral lens, then they're going to do well. Why is surgery technically difficult? Priya, why do you think surgery is technically difficult?
Thinning near the area of the limbus.
So the thinning is very close to the limbus. So what?
The amount of tissue to put the graft on. Does that affect your sutures when you're suturing the graft?
It does. Makes the surgery a little bit more difficult. What about the post-op course? Let's say you decide to incorporate the entire ectatic area, putting the inferior edge of your donor within 0.5 millimeter to 1 millimeter from the limbus. What are the 3 problems that graft is going to face?
A lot of higher rate of rejection because you're closer to the limbus.
So rejection is one.
Astigmatism, irregular.
You can, well, not really, because you can put in a 9 millimeter graft and go all the way up, and the astigmatism will not be an issue. But maybe I'll give you one hint. If you look at your ruptured globes, when the laceration goes to the limbus, what do you have trouble dealing with ruptured globes when you have the opening extending to the limbus?
You have pulse pressure.
Yeah, the iris always is in your way, right? So with these cases, if you have a graft extending very close to the limbus, the chance of having IK touch is very high. The chance of having anterior synechia is high, and then the chance of having progressive anterior synechia, which leads to glaucoma, is higher. And the last one is vascularization, because you're very, very close to the limbus. So one way to deal with this is to fortify that area with a wedge graft, a crescenteric graft, could be lamellar or full thickness, like a 4-hour graft from 4 to 8 o'clock, could be lamellar or full thickness. You fortify that area, you wait a year, and then you do your standard central optical graft. Okay? So just something to consider. There are people who have advocated excising that area, just excising the ectatic area inferiorly, and then simply resuturing the cornea. From a tectonic point of view, that works very well, but of course, in that scenario, you are dealing with marked astigmatism. You know, you're going to take the flattened vertical meridian and you're going to steepen it dramatically, and then have to deal with that for many months to follow. So let's talk about keratoconus, which is the most common of these ectatic disorders. You know it's common. You guys see it all the time. And basically you have this central or inferocentral or inferotemporal bulging of the cornea. 50 per 100,000 is a lot, so you're going to see a lot of that. We think that there is a disposition, a family disposition. Still working on identifying the locus of the gene. We think we know kind of where it is. It is associated with atopy. It is associated with eye rubbing. Now, we don't think that eye rubbing causes keratoconus, but we think that somebody who has a predisposition to keratoconus, if they rub, they're going to distort their cornea. So many of these patients will admit to being eye rubbers. If they don't, a family member who's sitting in the chair in the room will say, oh yeah, he sinks his knuckles into his eyes all the time. So just something to think about. Obviously, you know it's a feature of Downs, and that creates a big dilemma, both as far as identifying the visual potential and then deciding, do you put a Downs patient through a graft, especially if they come esotropic like this and you suspect that one eye is densely amblyopic, do you put them through a graft on their only seeing eye? And this is something we discuss in clinic all the time. In 1991, I wrote a paper with Steve Wilson, and we called it Unilateral Keratoconus. We put together 4 cases where there was no hint of keratoconus in one eye whatsoever. And we all know that this is probably a bilateral disease, but we were convinced that there was no keratoconus in one eye. And the reviewers, the peer-reviewed journal reviewers, wrote very politely and said, you know, this paper must be presented by young researchers who, if they wait long enough, they will note that keratoconus will develop in the other eye. Nevertheless, I can tell you that I have followed 2 of these 4 patients now for 28 years, so I'm no longer a young researcher, and one eye is completely free of ectatic disease. So we do think there is such a thing as a unilateral cone. If you had a chance to sit around the multiple-necked microscope in Dr. Eagle's office, you've seen his famous description, which is an interruption in Bowman's layer that is kind of pathognomonic, not necessarily for keratoconus, but for these 3 ectasias. There are breaks in Bowman's layer. It's kind of cool when you identify Bowman's layer and then identify an interruption in Bowman's. And you could have breaks in Decimase membrane, and you know what that leads to. We'll get to that in a second. You can have some scarring, as you can see here. And almost always, the endothelium is well preserved. And that's why we were excited 10 years ago, some of us who started doing DALK, that maybe that's a better procedure than a full-thickness graft that adds to the risk of allograft rejection. So these are board questions. These are OCAP questions. So let's look at them. And anybody want to volunteer? So the scissoring effect is what you get with retinoscopy, right? With streak retinoscopy. You get a scissoring effect. But a very, very sensitive way of evaluating keratoconus is just dilating the pupil and looking at the cornea against a red reflex. Very helpful. David, what am I scrolling on? Not fair?
No, I just forgot. Yeah, when they look down, do you see the lower lid?
No, that's Munson's. That's Munson's, the indentation of the lower lid. And what am I trying to show here? So it's I'm taking a slit temporally, and I'm projecting it temporally across the cone, showing the shadow on the nose.
Right, the Rizzuti sign.
Yeah, yeah. And what is a Fleischer ring? Anybody want to volunteer? Fleischer ring?
It's deposition of iron at the base of the cone.
Cool. Almost all of them have a Fleischer ring. Now, Priya, since you were courageous to tell me what a Fleischer ring is, I'm going to point to something here. Is this railroad track here 1 break in Decimase membrane or 2 breaks in Decimase membrane? You have a 50% chance of being right. 1 break in Decimase membrane, right here, just
1 break.
1 break. Excellent. And why is there increased reflectivity on each edge of the break, do you think?
just from surrounding scarring?
Well, if you've seen the pathology, you have scrolling of Descemet's, and sometimes it protrudes into the anterior chamber. And that's a classical pathology slide. I don't know if I have it in this talk, but so you can't miss it. So what happens in an OCAP question is they will have a couple of those, and it will be one item of the 5 items, and will say these represent 2 breaks in Descemet's or represent 4 breaks in Descemet's. And obviously, if you know that, you get that one choice correct. And now, the only reason I'm showing you this is not because this is part of keratoconus. Most breaks in Descemet's membrane that lead to hydrops don't look like this, but just to show you vertical breaks in Descemet's membrane, which are usually caused by, Alice?
I'm sorry, what was that?
Vertical breaks in Descemet's membrane are usually caused, forget the subject of today's talk. What is the most common cause for vertical breaks in Descemet's membrane? If you had eyes in the back of your head, somebody behind you was kind of trying to mimic it for you.
Okay, forceps.
Yeah, forceps. And if they are horizontal or oblique, if the breaks in Descemet's membrane are horizontal or oblique, what is the most common?
High pressure.
Yeah. Congenital glaucoma, high pressure, usually those are the... So Vogt stress lines are these fine lines in the posterior stroma that you see in keratoconus. It's kind of cool when you see them. Nothing else looks like them. And then if you take your scleral depressor, yeah, I have a scleral depressor in my pocket, you know, cornea person, and you push a little bit on the eye, they disappear. Kind of cool, you know. So you push at the limbus, and the Vogt stria disappear. All right. You all know about topography being a diagnostic tool. So frequently somebody will come in like this, right eye, left eye, frank cone inferiorly. You can even see it on the slit lamp. But this is a very, very early cone in the other eye, just inferior steepening. And when you see this, you can't see any clinical finding. So this is what has been called topographic keratoconus, pre-keratoconus, keratoconus in situ. But it has an important ramification because if you see this picture on both eyes, you may not be impressed at all that the patient has an ectatic problem. And therefore, if they come to you for a laser vision correction a consultation, you would say, yeah, no problem doing laser vision correction. We can talk a little bit about that if you're interested. But if they come with a picture like this and slide in the left eye and a picture like this in the right eye, and even if they beg you to do laser vision correction on the right eye, you probably have to be very cautious, especially if they're young. If they're 50 and they look like this and their refraction has been stable and they've already cross-linked themselves, you know, with age, it may not be unreasonable to do a surface procedure on this eye. A subject for a different discussion, but nevertheless an important subject because we see it in our offices all the time. So here's inferior steepening that doesn't look typical, that looks kind of funny, and this has a big bearing on what the seniors are doing right now. How so? Well, if they come like with this picture and they have 3 diopters of withdrawal astigmatism, it is important to know whether they're wearing a contact lens or not. All right? Your attending is saying to you, okay, do we offer them a toric implant? It's reasonable to offer a patient with mild keratoconus a toric implant, especially if they're in their 60s and are likely to have been stable. That is reasonable. What is not reasonable is to operate on an eye that is unstable for a different reason than the underlying disease. So what could this represent? Anybody? What could this represent that is described in this line? Right. So contact lens warpage is an issue, and and it's an important issue. And Fahim, what's the basic rule if somebody is wearing a rigid gas permeable contact lens and they're ready for cataract surgery, they wear contact lens all the time, and how does your discussion with them go? Because all their friends don't need to wear glasses or contact lenses after their cataract surgery.
Well, they have to be out of the contact lenses for a set period of time. If it's a rigid gas permeable, obviously that'll probably be a longer amount of time than a soft contact lens because it'll affect your topography measurements in the Ks, and that'll obviously affect the IOL calculation when you put it in. So.
Right, so that's all correct. And okay, so the patient is sitting in front of you. What are you going to say to them? I cannot deliver emetropia to you without you being out of your contacts. Well, doc, I don't have backup glasses at home, and I can't see without my contacts.
Or you can also let them know that, if they have keratoconus and they're wearing RGPs, that after cataract surgery, they might need a secondary corneal surgery, I guess, to improve your visual outcome. Is that where we're going?
No, that's not where I'm going with this, but that's cool. That's cool. That's cool. But no, remember, they're seeing well with their contact lenses.
Okay.
They're seeing well until about 2 years ago, but now they developed the cataract. They're already 65 years old, so they didn't need that corneal procedure that you're talking about.
They can go back in their contact lenses.
Yeah, you may have to stay in your contact lens, or, Mrs. Smith, you can get out of your contact lenses, go back to your doctor, get a temporary pair of glasses, but I can't see with glasses. Not as well as with your contacts, I understand that. And then you got to be out of your contact a certain period of time. And you may have heard the formula 3 weeks per decade of rigid gas permeable contact lens wear. But that's not written in stone. The idea, and this is why I'm so proud of this slide right here, and this is my own, not my own eye, but my own patient. So this is the same eye here, and look how the topography changed over a period of time out of a contact lens. This is pretty dramatic. And if they're going in this direction and they stabilize here, you certainly can give them a toric implant and make them very, very happy. Is that helpful? All right. Until 2 weeks ago, 3 weeks ago, what happened in the world of cornea 3 weeks ago?
Cross-linking drug approved.
Yeah. I mean, finally, cross-linking was approved in the United States, basically 10 years after the rest of the world. Unfortunately, the protocol that has been approved is a protocol that many people are not using anymore, but that's the subject of a different conversation. Michelle, before cross-linking was an option, patient comes in at the age of 20. They are told by their doctor that they have increasing astigmatism. You happen to have drifted into the field of cornea. Don't wish it for you, but you happen to have drifted into the field of cornea. And you are now the expert. And the patient never heard the word keratoconus. And you make the diagnosis of keratoconus. You explain everything about it. They're no longer able to see well with glasses. How does your discussion go?
So before cross-linking was an option, usually we would have people fit in rigid gas permeable contact lenses.
And that's been the standard of care for a long time, and I think it's still a reasonable standard of care even today. If the person is young, the family wants to know, are there any other options to arrest this process? Until 10 years ago outside the United States and 3 weeks ago in the US, we had no other way to arrest the process or to slow it down. So the discussion went glasses, then a rigid gas permeable contact lens. There are some high toric soft lenses that can be used. And when that fails, the next step was some form of corneal procedure. So if you choose in your practice to fit contact lenses, and the last contact lens I fit was as a senior resident, somehow I abhorred the practice. Doesn't make it bad. A lot of people are making a very good living fitting contact lenses in ophthalmology. Just didn't like it. You can't do everything, even within a specialty. Even if you go in the retina, you may decide, and even if macular translocation was popular, you may, not anymore, but you may decide, I don't want to do macular translocation, you know. So you can't do everything, but it was an important part of a cornea practice. Elizabeth Cohen, who was our chief of service for many, many years, I think 50% of her practice was fitting contact lenses, and she was extremely good at it, you know. But so if you decide to do that, then this is something you need to learn more about. Let's talk about surgical management. So anybody want to tell me, this is my own patient, 30 seconds into their surgical procedure, what did I do on this cornea? Anyone? Yeah, I mean, basically, but I didn't do it as a treatment modality because it was done 50 years ago. Just cook the cornea to flatten it, and it gives you temporary reprieve for a few weeks to a few months. But why do you think I did it in the beginning of a graft, at the beginning of a graft? Why do you think I cooked the cornea? What am I trying to make? So let's say the cornea looks like this, which it did, and I made it more of a normal curvature. And the reason I'm doing that is because depending on what tree fine you're using, if it looks like this and it's bulging into the tree fine, when the blade comes down, it's going to undercut the recipient. And therefore, it's going to gape the posterior aspect of the incision. And Michael knows all about that. The gaping of the posterior aspect of the incision if you cut the cornea with the cone still being steep. So the idea of cooking the central part of the cornea is to flatten it. So just to share with you a couple of factoids that are interesting, because I'm leaving for ASCRS this afternoon. I'm going to be giving 2 DALK courses. I'm going to talk about complications of DALK. And we know that DALK, which is popular in Europe, South America, the Far East, is not that popular in the United States. It's a challenging procedure, but that's not because we're bad surgeons, but we have the luxury of having excellent donor tissue. And we know that corneal transplantation, specifically low-risk corneal transplantation, meaning in the absence of vascularization, is the most successful type of solid organ transplantation, which I know you all know. What you may not know is corneal transplantation, full thickness, paired to the diagnosis of a keratoconus, is the most successful of all corneal transplantation, which is kind of a cool factoid. Morning, Roger. And therefore, it is hard to abandon a procedure that works so well and has worked so well for 40 to 50 years in the name of another procedure called DALK. We'll talk a little bit about that. Intracorneal rings, been around for a while. They are very artsy. They absolutely work for mild to moderate keratoconus, and they decrease the astigmatism significantly. The purpose of an intracorneal ring is not necessarily in and of itself to improve the unaided vision, although frequently it does, but to make the patient a better candidate for a rigid gas permeable contact lens, or even for spectacle correction. So, updated this slide this week. Collagen cross-linking. And anybody want to tell me what collagen cross-linking is about? Any volunteer? Maybe Tim.
So it's riboflavin. You apply riboflavin.
No, not as much what are we doing. Yes, you apply riboflavin and you expose it to a UV source. And so what happens?
The goal is to prevent progression. So it's not going to fix what's already the ectasia of the cornea, but the goal is to prevent it from getting worse.
Through what mechanism?
You're cross-linking the collagen, so it's not having further.
You're correct. Everything you're saying is correct. I'm looking for one more descriptive aspect. What are you doing to the cornea by cross-linking it?
stabilizing it?
Yeah, you're stiffening it. Okay? Kind of looking for that word because that's the word that's being used in the business. You're basically aging it prematurely because my cornea is more cross-linked than your cornea just because I've been on the planet longer. Yeah, exposed to UV light, and it's a stiffer cornea. If you have the privilege to work with a younger cornea, a younger donor, you'll see how flexible it is. If you have the privilege to work with a 2-year-old cornea, it's very hard to handle. Even if it does not have, an ectatic process. So the cornea stiffens with age, and what you're doing with UV light applied to riboflavin, with or without the epithelium being removed, is to stiffen the cornea and therefore to arrest the progressive ectatic process and sometimes reverse some of it. All right. So anybody want to take the issue of hydrops because there's an interesting development in hydrops? Michael, tell me a little bit about hydrops. I know the cornea is the dust cover for the retina, but still, got to look through it. So if you have a patient with hydrops, it's hard to see to do your work. So what is hydrops?
So it's an acute rupture in decimate, leading to immense amount of corneal edema.
Correct. And what has been the time-honored modality for treating hydrops? Time. And what else? Cycloplegic, maybe a hypertonic agent, prophylactic antibiotic. Is there any indication to do an urgent corneal transplant?
No, but recently I was talking to one of the cornea specialists who was talking about an interesting intervention of injecting some C3F8 to tamponade the posterior aspect of the cornea.
And how do you think, and what is the concentration of C3F8 that you'll be using a lot of come July to achieve this goal?
That I was asking this question and did not get an answer.
Okay, so basically if you're using a C3F8 or SF6, you are using an isoexpansile concentration. We use it a lot with DMEC. And the isoexpansile concentration of SF6 is 20% and of C3F8 14 to 15%. And how on earth does that work?
That was what I was going to ask you.
Oh, okay, all right. Basically, you're trying to approximate the edges of Descemet's membrane. I think that procedure has come and gone, right?
You don't think it does anything?
Well, it can work in certain patients, but it's not an effective procedure the way I see it. Backing up a little bit to the concept that there is no role for full thickness transplantation, essentially that's the correct answer, and that is the answer to an OCAP question. But there's an exception to that. Sometimes the fissure is so big in Descemet's membrane that you have a fistula of fluid going from the anterior chamber all the way to the subepithelial space. So when you're looking at the patient in the emergency room, the only thing preventing a gush of fluid out of the eye is the 5-cell layer thick epithelium. That may be an exception to the rule where you may want to do a transplant sooner than later. But the procedure that's gaining popularity is suturing Descemet's membrane, meaning putting a full thickness embrocation suture and approximating Descemet's membrane, kind of scarring it down and resolving this phenomenon quicker than just waiting and giving them Euro 128 and using the tincture of time. Okay? So that's why I just added it late last night to this slide. This is a typical reading by Ralph Eagle. And the reason I put it up, you don't have to read it, just look at the yellow. Ralph loved to say, and the endothelium is well preserved. Because if you are removing a full thickness cornea with keratoconus, the one layer that is normal almost all the time is the endothelium. So you have basically exposed them to an immune antigenic stimulus, because endothelial rejection is the most common type of allograft rejection. So an antigenic stimulus that patient doesn't need. Okay? That's why many of us got interested about 10, 12 years ago in DALK. So one of the things that we are now talking about, and which is exciting in cornea, for 40 years, there was very little exciting in cornea. We'd go to meeting after meeting where people would talk about suturing technique. Imagine year after year after year hearing about different suturing techniques to decrease astigmatism and so on. But now we have this whole thing called layer-specific keratoplasty, where we can replace different layers of the cornea. And when you are looking for your options of what you can do with a cornea, you have multiple options now. The one that applies to the corneal ectasias is the second one you see up there, anterior lamellar keratoplasty. Okay? These 5 items include all corneal procedures available to you. Anterior lamellar keratoplasty procedures are the ones that are being used as an alternative to full thickness transplantation to penetrating keratoplasty for keratoconus. All right? And in DALK, deep anterior lamellar keratoplasty, you are basically replacing the anterior 96 to 98% of the cornea, leaving Descemet's membrane and the endothelium behind, and therefore decreasing the antigenic stimulus. In the United States, I would like to impress you that we are doing more endothelial grafts than full thickness grafts. But I would also like to impress you that we are not doing very many anterior lamellar grafts. Okay? So this procedure is still not extremely popular in the United States. The indications for DALK, do we have to finish at 8:20 or 8:30? 8:20. So I'm going to move a little bit quicker. I'll stop asking you questions because I want to show you some videos. The indications for DALK, ectasias, dystrophies. I have to ask you this question because this is an OCAP question. Why is macular dystrophy, why does it have a question mark? Why is it maybe not an ideal procedure, ideal indication for DALK? Okay. Yeah, there is an endotheliopathy. Some people feel that it's a comorbidity with Fuchs. Most of us feel no, the guttae look different, but there is an endotheliopathy. So you may want to offer them a full thickness graft, or you may argue, let's do a DALK, see how they do, and if the endothelium fails, we'll then do an EK behind a DALK. So, all right, and then of course scars. Contraindications to DALK, this is not a procedure for endothelial failure. This is not a procedure for endothelial dysfunction. This is an absolute contraindication. Relative contraindication is epithelial dysfunction. What does that mean? If you have limbal stem cell deficiency, a DALK is not going to solve the problem. It will solve part of the problem. You'll be able to remove the anterior scar, but in the final analysis, you're going to need to do some type of concomitant surgery, some type of simultaneous surgery or stage surgery like a limbal stem cell transplant to solve that limbal stem cell problem. Okay? There are different types of anterior lamellar surgery. The one I'm going to talk about in the next few minutes is DALK. Now, the commonly purported advantage of DALK is that you are, by definition, eliminating primary endothelial graft failure because you're retaining the patient's own endothelium. You are eliminating one type, and the most common type, of allograft rejection, which is endothelial graft rejection, and therefore decreasing the total incidence of allograft rejection. But the one thing that is not frequently talked about, and you'll see it in the next slide, is the fact that you are working in a closed system if you are successful in doing DALK. The eye is never open to the world. And for those of you who did PKs in my era, at least before 2005, all of us have had more than one incidence of the terrible gray shadow coming up at us when the cornea is off. Terrible feeling. Hopefully you never see it. Most of you will never see it in phacoemulsification. But if you do anterior segment reconstruction, and you do a lot of retinal work, absolutely, you're going to see choroidals. And hopefully there are choroidal effusions, not choroidal hemorrhages or suprachoroidal hemorrhages. And hopefully if they're a closed system, you're doing retinal work, just raise the pressure in the eye and control the situation. But you don't have that option when the cornea is off. You just try to close the eye as quickly as possible. So what I like about it is the fact that there's no open eye time. And therefore the risk of a suprachoroidal event or even posterior pressure is not there. And that's pretty cool. Okay? Disadvantages? It is definitely a more difficult procedure than PK. There's a learning curve. And there's one common complication, easy to fix, called the double anterior chamber, beyond the scope of today's talk. I'm going to go ahead and skip through the animation. The reason I have this animation is because in 2002, when I listened to Professor Anwar, Muhammad Anwar, describe DALK to me, I just could not follow what he was saying. I really did not understand where the needle went and created the big bubble. So I created this animation, but I'm going to skip through it and show you one of my favorite cases. This is a patient who had an intact ring segment, did very well for a while, and then the vision dropped, so they needed something else done. All right? So I'll walk you through this, and I'll stop at certain points to show you a couple of important steps. So I'm removing the ring segment out of the eye, and I'm using the Hanna tree fine to do a partial thickness trephination. I'm going to inject, so here's a pearl. I'm about to inject air in the posterior stroma. The purpose is to get the air into the pre-Descemet's space. All right, so watch carefully. The cannula is simply in the posterior stroma. The pre-Descemet space is a potential space. You can't get the cannula into it. You just can't. But when you start injecting air, the pathway of least resistance is going to be posterior, and it's going to cleave Descemet's membrane off. So watch carefully. So far, this is what the military calls collateral damage. This is not the big bubble. But as soon as the big bubble starts developing, see how smooth the edges of the big bubble are? That's the big bubble. There is no mistaking about it. So you know you've gotten the big bubble. You know you've gotten the bubble in the correct space. I am now going to debulk the cornea, remove the anterior lamella, and I'm going to put a little bit of air in the anterior chamber. And the purpose of putting the air in the anterior chamber is to create this bubble in the anterior chamber, which behaves like a sausage dancing around the big bubble. See that sausage? If you have that air in the anterior chamber, you know that you have a big bubble anterior to Descemet's membrane, pushing that AC bubble peripherally. Okay? I'm removing the posterior lamella. And here's the coolest thing, which I want to share with you. So I'm going to put a bandage contact lens, but that's not important. Here's the coolest thing. For years, between 2005 and 2012, all of us believed that at this point, we were looking at Descemet's membrane. So I would say to the resident or the fellow, looking at Descemet's membrane, but something was funny about it. You could bounce a BSS cannula, 19-gauge BSS cannula, on the structure, pretty resistant. It was not popping. Now, the burst pressure of Descemet's membrane, if anybody wants to guess the burst pressure of Descemet's membrane, a number, multiples of 10.
90.
90? 30. But that's fair, okay? This structure here is burst pressure. No, so 30 is all it takes to pop Descemet's membrane. So all the times you're in the ER and you describe something as a dysmatocele, maybe it's not a dysmatocele. You know, that bulging structure coming through a completely melted cornea. Maybe it's not a dysmatocele because you know you can sit on it for weeks and sometimes it heals. A dysmatocele is not likely to heal. So what do you think we're looking at? Oh, yeah. Right. So Harminder Dua, fellow here, 1994, chairman at Nottingham, and his colleagues described the structure in the posterior stroma. Try to not think about the nomenclature because that's controversial. You're not supposed to have a structure named after you while you're still alive. You have to die first. But that's what has happened. There is a part of the posterior stroma that's about 10 to 20 microns thick and about 5 to 8 lamellae thick that is void of keratocytes. I know I'm boring you to tears, but this is so important. We're so excited about this. That has a bursting pressure of 700 millimeters of mercury. And it has huge ramifications, which many of the talks this weekend, especially tomorrow in New Orleans, will be about. All right? So we are not looking at Descemet's membrane here. So I covered with a bandaged contact lens, go to the donor. Once I'm secure that I'm doing a DALK, now I don't need Descemet's membrane on the donor anymore. So I'm going to peel it off. Imagine what a cruel thing I'm doing here. I mean, we spent a whole career avoiding doing this, right? And now I'm peeling this off because I don't need Descemet's membrane. I don't need the endothelium on the donor. I have the patient's own, and then I suture it into position. Okay? And you can use any suturing technique, either interrupted or combined suturing technique. All right? Any question about DALK? Yes, Priya?
Post-op, how can you tell in a post-op patient if they've had a PK or a DALK?
It's very tough. Early on you can, but later on it's very tough. But what is a distinguishing feature with DALK, you have some fine wrinkles in Descemet's membrane, or Dua's layer, or both. And they're usually concentric, with the limbus, and that distinguishes it. And some people feel that they are visually significant, but if so, minimally so. Okay, we need to wrap up. I'm going to just show you one more clip, and then we'll finish up. So what I'm going to do here is show you a different way of doing DALK. I'm going to debulk the cornea first and then create the big bubble. So I've removed the anterior lamella first, and then I'm going to inject the air. You can see that rounded appearance. This is the way some people like to do it. Donald Tan from Singapore likes this technique. Now I'm entering the anterior chamber. My assignment tomorrow, and I'll just kind of show you what I'm working on, hopefully sometime before tomorrow, is if you use the same technique that you normally use with cataract surgery and bevel your paracentesis, if you bevel your paracentesis, you may end up rupturing the bubble internally. So you want to go down with your knife kind of vertically so that you don't rupture the bubble internally. That's why you will see me very shortly when I'm decompressing the anterior chamber. I'm going to enter it kind of vertically with the diamond knife, so that if I go kind of bevel it, I can rupture the bubble internally and defeat the purpose. And look how cool this is. Now this takes tens of hours of mining video to find this and to show it to you, because this is a video showing the bubbles in the anterior chamber dancing around the big bubble. The big bubble is pre-Dua's, pushing Descemet's membrane Dua layer complex backwards, and the air that I injected into the anterior chamber is peripheral. Okay, so many of us are doing DALK now as an alternative to PK, and it has many advantages. Some disadvantages, mostly related to surgical technique. Let's wrap up. Questions, comments, observations, concerns? Very good. Thank you all for coming this morning.